class, we're going to go over Chapter 3 in your step-by-step textbook. And it's about ICD-10 outpatient coding and reporting guidelines. Now, you have guidelines located there in the front of your ICD-10 coding manual. And these are the official guidelines for coding and reporting. In Section 4, you're going to find the outpatient coding guidelines. The majority of services that a physician's going to provide are going to be outpatient services. So this chapter is going to start with assigning your I10 diagnosis codes for outpatient services in accordance with those guidelines. In the outpatient setting, the term first listed diagnosis is used instead of the principal diagnosis. And in inpatient settings, you hear that term principal diagnosis. In the outpatient setting, you hear the term as the first listed diagnosis. But it's basically the same thing, just used differently depending on the setting. In determining the first listed diagnosis, the coding conventions, as well as the general and disease-specific guidelines, are going to take precedence over the outpatient guidelines. Diagnoses are often not established at the time of that initial encounter. So sometimes it may take a physician a couple of visits before a diagnosis is actually confirmed. The most critical rule involves beginning your search for the correct code through your alphabetic index. Never begin searching initially in the tabular. So you'll start searching in your alphabetic index, and then you're going to move to your tabular section. Now, when it does take several visits for the physician to come up with a diagnosis, you will be using the signs and symptoms that occasioned that encounter. So if the physician doesn't know yet what the actual diagnosis is, then that first listed diagnosis is going to be a sign or a symptom. For example, if you have a patient that presents with the complaint of frequent heartburn, the physician might prescribe Prilosec because he's thinking that the patient probably has GERD, and maybe we'll have the patient come back in 10 days and see if that helped. But our diagnosis code for this visit is going to be frequent heartburn. Now, if the physician decides after the next visit that the patient does have GERD, then our diagnosis will switch to that. But until a diagnosis is confirmed in the outpatient setting, you're going to use the signs and the symptoms. Now remember, these guidelines are very important because they're going to give you the rules for coding. So you want to make sure that you have a good understanding about these guidelines, and make sure you have a tab on the different guidelines that you might want to look for sequencing what goes first and what goes second. In outpatient surgery, now this is when a patient presents for like that same day surgery. We're going to code the reason for the surgery as our first listed diagnosis because, remember, that's the reason for that encounter. Now, even if the surgery for some reason doesn't get performed, maybe the patient's blood pressure is too high or whatever, you're still going to code for the reason for that surgery. And then you may need to put another code to finish telling the story, such as Z53.09, which means that the procedure wasn't carried out due to other contraindication. When abstracting information from the medical record, so this is when you're reading the medical record and getting the information out of that medical record, the intent is to communicate the story of that patient encounter. That's what you're doing with coding. You're communicating the story of the patient encounter. Sometimes important information that contributes to the care of the patient may not even be an illness. As you read through the medical record, you want to ask yourself, is this information pertinent to the care that was provided to the patient? For example, the patient may have a history of cancer, but the cancer has been surgically removed. As another example, maybe a patient lives in a difficult circumstance at his home, and these circumstances are affecting the patient's health or are affecting the physician's ability to treat the patient's condition. There are also circumstances in which patients may need counseling, or they may have been exposed to a disease that they may or may not have contracted. The Z codes are assigned to report these types of encounters and help capture that story accurately. Sometimes the Z code will be the first listed diagnosis, and sometimes it will be a supplemental code. It's going to depend on the circumstance of the encounter. Chapter 20 in your I10 book classifies external causes. The external cause index is located right after the table of drugs and chemicals. Now make sure you have a tab here so you can get to this alphabetic index quickly if you need to. This index classifies environmental events like tornadoes or floods, circumstances, and other conditions as the cause of injury, as well as adverse effects. And these are all listed alphabetically in the external cause index. These codes are reported to clarify injury or adverse effect, and they are never reported as a first listed diagnosis. The code terms describe the external circumstances under which an accident, an injury, or an act of violence occurred. The main terms in the code index usually represent the type of accident or the type of violence, like an assault or a collision, and then it gives specific information about other circumstances. External cause codes have their own index, so remember that, and the external cause codes are not listed in the index of diseases. That's your first alphabetic index. When an external cause code is reported, remember it's always reported in addition to the diagnosis code or the injury code. The external cause codes are codes that provide just a little bit more details about what happened. Most groups of codes have includes or excludes notes that are going to provide further detail about assigning these external cause codes. Observation stay is when a patient is admitted for observation for a medical condition. We're then going to assign a code for the medical condition as the first listed diagnosis. When a patient presents for outpatient surgery and then maybe develops some type of a complication that requires them to be admitted to the hospital, we're going to code the reason for the surgery as that first reported diagnosis, which was the reason for the encounter. And then we're going to follow that up with the codes for the complication as the secondary diagnosis. The two categories of Z codes that report observation are Z03 and Z04. These observation codes are reported only as the first listed diagnosis for medical observation if there is a suspected condition and then that condition is ruled out. Other codes may be reported in addition to observation codes, but only when that condition or conditions are unrelated to the reason for the observation. For example, a patient admitted for observation for a suspected exposure to anthrax would be Z03.810. And then they demonstrate no signs or symptoms, but they're admitted to observation to determine if the exposure will result in the patient actually developing anthrax. If the patient also has another diagnosis, like maybe primary hypertension, then the hypertension can be reported may be reported as it is unrelated to the anthrax exposure and observation. We also have a guideline for coexisting conditions. You may have already been working some in your textbook and practiced at selecting the first listed diagnosis. And you know that it is possible for that first listed diagnosis to sometimes be a symptom. The important information in this guideline is that additional codes should be assigned for any coexisting conditions that are present or that are treated during that visit or that encounter. Sometimes there is more than one symptom that is present. An example of that would be an established patient was seen in the clinic for dyspnea on exertion. The patient has hypertension and Graves' disease. The physician can't find a reason for the dyspnea. The patient's medication for hypertension and Graves' disease were refilled during this visit. So we will code the code for dyspnea, for the hypertension, and for the Graves' disease. Another example would be that the patient presents with shortness of breath due to asthma. The physician prescribes nebulizer treatments. The patient is morbidly obese, making examination and treatment more complex. So our first listed diagnosis is the reason for that encounter, which is asthma. Remember, shortness of breath is a symptom of asthma. So we're not going to code that in the outpatient setting. And then we have that coexisting condition that is affecting treatment, and it's obesity. For uncertain diagnoses, in an inpatient setting, uncertain diagnoses are actually reported, but not in the outpatient setting. Uncertain diagnoses are not reported in the outpatient setting, so we're never going to report anything that's listed as probable, suspected, questionable. Maybe the physician's ruling something out, like in that example a few slides back on GERD and heartburn. We don't code a working diagnosis or any of that type of terms. In the outpatient setting, instead of coding an uncertain diagnosis, we're going to report the symptoms, the signs, if there were abnormal test results, or other reason for that encounter. And an example of uncertain diagnosis would be a chest x-ray is ordered to rule out pneumonia. The patient has cough and fever, and then when the physician looks at that x-ray, he sees that that x-ray is normal. So we're going to code that cough and fever. Those are the signs or the symptoms that the patient is experiencing. The pneumonia can't be coded as it's documented as rule out, and we're in the outpatient setting. And we also see with the x-ray that it was not confirmed. So the patient did not even have pneumonia. A 55-year-old male was seen with loss of appetite and jaundice. Further diagnostic studies are needed for that suspected cancer of the pancreas. So in this instance, we're going to be coding for the loss of appetite and the jaundice, R17 for the jaundice, R63.0 for the loss of appetite, and then we won't be assigning a code for cancer of the pancreas because it is documented as suspected, and we're coding in the we're coding in the outpatient, and we're not going to code things that are probable, suspected, questionable, and so on. If a patient has a chronic condition that's treated on an ongoing basis, you can report that condition as many times as the patient receives care or treatment for the conditions. Chronic diseases are things like asthma, diabetes, hypertension, things like that. Let's just look at an example of a chronic condition. An established patient is seen for equal management of mild, intermittent, uncomplicated asthma, and the patient also has type 2 diabetes. So you read through the note and you see that the patient or the physician refills medication for asthma and diabetes. His exam is looking at both of those organ systems. So you're going to code both diabetes and asthma. And in that instance, either one of those could have been the first listed diagnosis because they were both being treated pretty equally. You want to make sure that you code all documented conditions that coexist at the time of this encounter or this visit and that require or affect the patient care, treatment, or management. Now you don't want to code conditions that were previously treated and they no longer exist. But we do have history codes, so sometimes the history of one of those illnesses is important. So in those instances, you'll use a history code. For example, you may be coding a patient that had a previous cancer that's no longer being treated, and maybe it was 5-10 years ago. But today they may be complaining of something that makes you believe that that cancer would be pertinent, and you should document or code that as well. Maybe even thinking of that in a family history type situation. Maybe they have a family history of breast cancer and the patient's being seen today with a lump in her breast. So you could see how that family history would be pertinent to today's visit. For patients receiving diagnostic services only during an encounter or a visit, and this would be things like maybe an EKG or some type of an imaging test, an x-ray, things like that. When this happens, you want to sequence first the diagnosis, the condition, the problem, or the other reason for the encounter that you read there in the medical records. That's chiefly responsible for that service that's being done. Codes for other diagnoses like chronic conditions can be sequenced as additional diagnoses. And an example of that would be the patient presents for a diagnostic imaging for the left central breast mass. You're going to report N63 for an unspecified breast lump for that test that you're doing. Now later, after maybe a biopsy, they find out that it's a malignant neoplasm. At that point, for any services done after that diagnosis is made, you would report that malignant neoplasm. For patients that are receiving only therapeutic services during that encounter, you're going to sequence first the diagnosis, the condition, the problem, or the other reason for that encounter that's shown in the medical record to be chiefly responsible for that service. Codes for other diagnoses, again, like chronic conditions, can be sequenced as an additional diagnosis. Now there is an exception to this guideline. The only exception to this rule is when the primary reason for that admission or that encounter is for chemotherapy or radiation. The appropriate Z code for the service is going to be listed first, and then that diagnosis or that problem will be listed next. And here's an example of that on your screen. The patient is getting outpatient chemotherapy for right breast cancer. And then you're going to code the chemotherapy code because that's what they're there for. That's why they presented, Z51.11. And then you'll code the diagnosis code for the malignant neoplasm. For patients that are receiving a preoperative evaluation only, you're going to sequence first a code from subcategory Z01.81, and then it's broken down into exactly what type of preoperative evaluation is being done. Is it a cardiovascular exam, a respiratory exam, maybe some type of a lab work, or a pre-op exam for someone before they're having chemotherapy. Usually a surgeon is going to want this type of preoperative clearance performed by the patient's primary care provider, often due to chronic pre-existing conditions. When the primary care provider reports the diagnosis for the visit, he's going to list first one of these Z codes, and then he is going to list the reason for the upcoming surgery, and then he will code anything that he finds like diabetes, hypertension, and such. So an example of that would be maybe a patient with diabetes was sent for a preoperative exam, maybe like of a cardiovascular exam before the patient has some type of, let's see, maybe the patient's getting ready to have cataract surgery, and the physician, maybe the patient's also complained of a little bit of chest pain. So in that example, we're going to list first that Z01.8110 for the pre-op examination, And then remember the type of surgery that the patient was going to have. The patient was going to have cataract surgery for a cataract. So your next diagnosis would be for that cataract. And then the patient also has diabetes, and maybe the physician finds that the patient also has some type of cardiac ischemia. So those would be listed as the next diagnoses. For ambulatory surgery, we're going to code the diagnosis for which the surgery was performed. If the postoperative diagnosis is known to be different from the preoperative diagnosis, at the time the diagnosis is confirmed, we're definitely going to pick the post-operative diagnosis to report on our insurance claim form. And an example of that would be the patient has an EGD for upper gastrointestinal bleeding, and then that would be the preoperative diagnosis. The post-operative diagnosis is upper gastrointestinal bleeding, and they can't determine where that's coming from. Another example, that's when they're the same, the pre and the post was the same. Another example, if they're different, would be the patient has an EGD for upper gastrointestinal bleeding, and then the post-operative diagnosis says gastrointestinal bleeding due to a gastric ulcer. So we're going to want to make sure that we will report that post-operative diagnosis for that surgery. There are specific rules for reporting routine prenatal visits that are provided in the outpatient setting. If it's a routine outpatient prenatal visit with no complications present, we're going to choose a code from the Z34 category for supervision of a routine pregnancy. And an example of that would be a 19-year-old female presents for their initial prenatal exam. It's the first pregnancy. You would code that as Z34.00. For prenatal outpatient visits on high-risk patients, a code from category 009. This is for a supervision of a high-risk pregnancy. We're going to list that as our first listed diagnosis. Secondary Chapter 15 codes may be used in conjunction with these codes if that's appropriate. You should work on your chapter exercises. You have answers to those in the back of your book. You should work on your chapter reviews to make sure you have a good understanding of this chapter. If you have any questions, make sure that you contact me. You can email me, you can text me, or you can call me. I'm available 9 a.m. to 9 p.m. Eastern Standard Time. And you can find my telephone text information in your classroom under faculty availability. I hope this has helped you gain a better understanding of Chapter 3. Thank you.